From more than a decade, our team is utilizing this elegant pretemporal transcavernous approach for various indications, and the most important limiting factor of this approach has been cranial nerve morbidities, mainly the third, fourth, fifth, and sixth cranial nerve. Through this case of posterior clinoid process chondrosarcoma, we would like to highlight our current practice to overcome the same. So, with every transcavernous approach, we are doing multimodal intraoperative neuromonitoring. Here, we are going to demonstrate the utility of triggered electromyography monitoring the compound muscle action potential. A 22-year-old male presented with right-sided headache and facial pain in the fifth nerve distribution on examination. Right coronary reflex was diminished by 50% and there was right sixth nerve palsy localizing the lesion near the Dorello's canal. In neuroimaging, contrast-enhanced MRI brain and CT bone window was done. A contrast-enhanced lesion occupying the right cavernous sinus, shifting the cavernous ICA medially was appreciated. Lesion seems to be arising from posterior clinoid process, the part of sphenoid bone, confirmed with CT bone window, and lesion is having varied consistency. The medial part is more bony and lateral part is looking soft. Patient was positioned supine, head extension by 30 degree, rotation to opposite side by 30 degree. 25 millimeter long, 0.45 millimeter diameter, non-insulated needle were used. The transconjunctival scoring of superior oblique medial rectus lateral rectus muscle was done and masseter muscle was also scored. This is to demonstrate the transconjunctival scoring of superior oblique muscle. This part was done by our neuro-ophthalmology colleague. Medial rectus was also scored and this is the final positioning. This is the baseline compound muscle action potential showing no response with lateral rectus stimulation. Right frontotemporal craniotomy was done. Zygoma was lowered. This green line was showing original zygoma lining and blue line is showing this much of zygoma was lower. Craniotomy edge was flushed with the base. This is the stimulation of the mandibular division of the fifth nerve. Now we are performing the posterior orbitotomy. We should take utmost care not to injure the periorbita. Horizontal segment of superior orbital fissure is exposed, sharply dissecting the orbitomeningeal band from the anterior clinoid process and now dividing the orbitomeningeal band in the line of dural groove. The sharp division is the key to protect the nerve lying between the outer and inner membrane of the cavernous sinus. We can appreciate the maxillary division of the fifth nerve. Now we are stimulating the third nerve, confirm with CMAP. Anterior root of the anterior clinoid process was removed by deroofing the optic canal. You can see the tumor projecting through the lateral wall of the cavernous sinus. The fifth nerve branches are draping over it. So a cut was given in the direction of the V2 division. Fourth nerve was stimulated and compound muscle action potential was confirmed. Further dissection revealed all the cranial nerves lying on the lateral wall of the cavernous sinus, third, fourth, V1 and V2 division. And now we understand where is our Parkinson's triangle. between the fourth and V1 as shown by this blue triangle. This triangle was utilized to decompress this tumor. This tumor lateral part was soft and suckable, and medial part was very solid, rocky hard, was removed piecemeal with the help of roungers, and now we are going to increase our exposure by dividing between the fourth and V1 division of the fifth nerve. Piecemeal removal of the tumor was done. We can appreciate all the three branches of the trigeminal nerve and Gasserian ganglion. So we have reached to the Dorello's canal area. Sixth nerve was appreciated, but it was not showing any response on triggered EMG, and that was very obvious because patient was having preoperative sixth nerve palsy. So after safe removal of the soft component and then some part of the solid component, repair was started by putting small fat pieces wrapped with surgicel. Then the dead space created between the dura mater propria of temporal lobe and cavernous sinus membrane was filled with these small pieces of fat. Fibrin glue was put over it. Post-op CT scan revealed near total excision of the tumor, no operative site hematoma, no retraction edema of temporal lobe. In early post-operative period, patient shown right sixth nerve persistent palsy. But after 3 months post-operative period, patient shown near total excision of the tumor and complete recovery of the right sixth nerve palsy. The posterior clinoid process chondrosarcoma is a rare entity and only one case report is found in the literature. The triggered EMG and CMAP recording is the standard of care, and these monitoring will lead to gratifying outcome as demonstrated. This is my disclosure. Thank you.